Just wait a couple seconds for everyone to get situated. All right, well, let's get started. Good afternoon. Thanks for joining us for the OHCA webinar on routine state testing. My name is Catherine Van. I'm the communications coordinator for the Oregon Healthcare Association. We're going to have about a 30-minute presentation from DHS and OHA, and then we'll kick it off to the Q&A portion. And just a few announcements before we begin. All attendees have been muted to eliminate any background noise. But if you have a question, please submit them in the chat feature at the bottom of your screen. I'll do my best to monitor them during the Q&A portion of this webinar. So with that, let's get started with your presenters, Mike McCormick and Rachel Currens with DHS.
Thank you, Catherine. Good afternoon, everybody. For those of you who don't know me, my name is Mike McCormick, and I'm the Interim Director for the Aging and People with Disabilities Program. And thank you to all of you who are attending here today. You can see by the slide the overview of the content that we're going to cover today. Give you some background on why we're doing what we're doing, going over the testing rule, answering some of your frequently asked questions, talking about financing. You can see, though, let's move to the next slide, that we're also adding some things differently from a session that we did just 1 week ago. We're going to be addressing the clinical guidance from the Oregon Health Authority on the use of antigen testing in nursing homes. We're going to be talking about reporting. I am going, due to so much popular demand, we will be addressing the indoor visitation policy and taking any questions that all of you have. So I hope today is of value to you. So let's get started. So I'm going to give some key stats on what's going on in long-term care world from a global perspective. Almost all of you are probably aware that in March, we developed a strategy involving the utilization of executive orders whenever there was a suspected or a confirmed case of COVID-19 in a long-term care facility, and that included either a resident or a staff member. So here are some key statistics. The data is about a week old, however, but it still illustrates just how much work has been done. For assisted living facilities and residential care facilities, we've issued a total of 669 executive orders, and those went out to 558 facilities. So the difference between those numbers is some facilities received multiple executive orders. So the percentage of ALFs and RCFs that received an executive order is 66%. Nursing facilities, we've issued 689, and you can see 129 of them received them. So a lot of them received multiple executive orders, and 98% across the entire state had received them. So, you know, why did we adopt a testing rule for our long-term care facilities? Well, because we know that the vast majority of outbreaks were caused by staff bringing the facility into the virus. Fewer than 13% of the COVID cases in Oregon are associated with congregate living settings, but the deaths account for 57% of all deaths. So routine testing can really reduce the likelihood and the severity of the outbreaks in the long-term care facilities. So, you know, let me first acknowledge that I cannot begin to imagine how challenging it is to be operating a long-term care facility through what probably feels like a daily change in the regulatory guidance that we issue. I get it, I acknowledge it. I will also acknowledge that the vast majority of you have been keeping up, and the vast majority of you have been doing wonderfully in controlling COVID in your buildings. And for that, I want to express my deepest appreciation. However, we do still, as recently as this week, we are seeing facilities that are caught flat-footed, unprepared for when COVID entered their building, having no plan at all, and that is just simply not acceptable. We're in month 9 of this pandemic, and so I would be remiss if I didn't take this opportunity to reiterate the need for preventative preparation, because it's not a matter of, you know, for almost all of you, if COVID's going to enter your building, it's a question of when. And so, you know, you really have to make sure that all of your staff members are utilizing PPE in the manner intended at all times. You have to have a plan for staffing. I can tell you that when COVID enters your building, you're going to have a certain percentage of your staff who are going to be unable to or unwilling to work. I don't know if it's going to be 5%, 10%, 25, 50, 75. We've seen 100% turnover of all direct care staff in your buildings. You need to be able to plan for that contingency, whether that's having multiple staffing agency contracts, whether it's over hiring of direct care staff, whether it's having cooperative agreements with your sister facilities. It's really, really critical. And you also need to have a plan for how you're going to cohort staff so that, you know, staff aren't serving both COVID positive individuals and COVID negative individuals. You need to have a place for cohorting within your facility. And of course, any technical assistance that anyone needs, we are more than happy to provide. So once again, please make sure you have good plans to prepare for when COVID enters your building, and please accept my most sincere gratitude to the numerous facilities that are just doing an awesome job in managing COVID in your facilities. So now I would like to take this opportunity to introduce Rachel Kearns-Henry. She is an executive leader in a new joint program between the Oregon Department of Human Services and the Oregon Health Authority. The name of the organization is the COVID Response and Recovery Unit, and we call it the CRU, C-R-R-U. So I'm going to hand it over to Rachel, who's been a great partner on the testing role, to take it over from here. Thank you, Rachel.
Hi, thanks, Mike. I appreciate that. And thank you to OCA for presenting and hosting this webinar today. First, I want to give some background. As Mike mentioned, and you all know, back in June, the governor released a long-term care facility testing plan. There were 2 objectives. The first was to complete baseline testing for all residents and staff by the end of September. And the second was to prepare for ongoing completion of monthly routine testing after that September 30th date. I want to thank all of you. As Mike mentioned, all of you have been working extremely hard, and we are very happy that facilities successfully completed the baseline testing requirements. That was our preparation ground, if you will, before going into this next phase, phase 2 of the routine staff testing. We're here today because since that time in June, when the governor released the long-term testing plan, the CMS also issued testing guidance in September that requires all nursing facilities in the United States to test at least once a month, and in some cases, once or twice a week. Additionally, the federal HHS issued point-of-care antigen testing devices to all nursing facilities. So with those changes, we as well must change and adapt to make sure that we are evolving with the changing pandemic and the need to protect our residents and in our long-term care facilities. So with that, the summary you see here are the updates to phase 2 of the governor's long-term care facility plan. We're aligning with the federal requirements for routine testing for staff and associated staff. The new requirements start on November 1st, and In these bullets, you will see the links to many of the materials that we're going to be going over today in summary, but we wanted to make sure you have a snapshot, if you will, on this page to all of the different links to the fact sheets that you may need to understand this policy. For today's presentation, I'm going to first focus on the definition section and the routine staff testing requirements section that are bolded here. What I want you to see as well is Chapter 411, Division 60 also had additional sections that had some updates in the rule. We will be going through those updates to that rule later in the presentation. But first, we're going to highlight the definition and the routine staff testing requirements that changed since the June release. So the first item that changed was the definition. Back in June, when DHS and OHA worked together on the testing definitions and testing plan, at first, the first initial rule in June had an expansive definition of associated staff. We heard feedback and we narrowed the definition. So the definition in which many of you worked to ensure that you met the baseline testing requirements for September 30 included a definition of associated staff that meant individuals providing direct care services via contractual relationship with the facility, period. The definition that you see in front of you includes a list that includes volunteers, hospice, caregivers who provide care and services to residents on behalf of a facility, individuals providing environmental, housekeeping, laundry, or food services via a contractual relationship with the facility, and students in the facility's nursing aid training program from affiliated academic institutions. Much of that language that I just read comes directly from the CMS guidance, and we are seeking to align with the federal rule. This does mean that more people entering nursing facilities, assisted living facilities, and residential care facilities will need to be tested. And it does mean that by putting this in this rule as the responsibility, the long-term care facilities are responsible for ensuring that the staff that are entering the facilities have received and are in compliance with these testing requirements. So the routine staff testing, the language that we have here shows directly that we have aligned with the CMS guidance. And I just want to pause. The approach that I'm taking here is I'm going to show you the rule language on the definition and the rule, and then I'm going to give some interpretive guidance to help understand and interpret the rule language. Two other provisions in the routine staff testing requirements. Second, we want you to note that if a facility is unable to complete the required testing, they must notify the department. We will have an email address later on in the presentation, so you will know how to comply with this. And three, conducting testing in a manner that's consistent with practices for conducting COVID tests as defined by OHA clinical guidance. We're trying to marry much of the DHS requirements to follow and align with OHA clinical guidance, and that's the partnership that we sought to include in the rule. Rule language here that identifies the documentation requirements. You can see the general language in the rule identifies that we do expect that facility staff and associated staff testing, that there will be documentation of that testing was complete. A facility must have this. We have clarification later on that will identify what that means exactly and what we would constitute documentation. Number 5, you'll see that upon identification, we expect that that the facility would take actions to prevent the transmission of COVID. And we do have many of those policies defined in our OHA clinical guidance. Item 6, ensuring that facilities have procedures for addressing staff and associated staff who refuse testing, who are unable to be tested. This is the same language that we had included in the June provision. Now, we've heard from many of you, this definition of associated staff is confusing. We're not quite sure how should we interpret who may be coming in our door. And so part of what we are offering for you to consider is the following interpretive guidance to define individuals or caregivers who provide care and services to residents on behalf of the facility. So first, we would ask you to consider, do you have a contractual relationship with that individual as a facility? Does that individual have a close and prolonged contact with residents for more than 15 minutes within 6 feet? If an individual meets both of that criteria, then we would say you've reached that yes threshold, and you would look at the following question. Does the individual provide services to many residents in multiple buildings and facilities? Or does the individual who enters a facility come in more than once a week? So if the individual meets the top 2 criteria and one of the bottom 2 criteria, we would suggest that yes, that individual would meet the definition of the staff or associated staff and need to be compliant with testing. Routine testing of staff is going to be more frequent than once a month. So we do have a link to the CMS guidelines, and we're showing below this chart, the CMS guidelines that shows the community COVID activity level definitions with county positivity rates under 5, between 5 and 10%, and over 10, and associated with the minimum testing frequency. So facilities should use their county positivity rate in the prior week as the trigger for staff testing frequency. As we interpret this, facilities must choose either the CMS or the OHA positivity rates and use one of those resources, but you must be consistent in gathering the data, checking the positivity, and setting a specific recurring day for biweekly review and document what you are following. We included links to both the CMS and the OHA positivity. Now, we've also been asked the question, why do you have both? Now, I would note the reason why we have both the CMS and the OHA positivity rates are because the CMS definition, which went into effect, the CMS rules for nursing facilities went into effect at the beginning of September, and it required that nursing facilities start using the CMS positivity rate, or they could use the state rate. So there was a flexibility and a requirement to have that flexibility in the federal rule, which is why we have included this flexibility as well in the state rule. Facilities need to raise their testing frequency if the positivity rate goes up a tier, but they also then would remain in that same tier for 2 consecutive weeks at the higher rate if the positivity rate goes down a tier. And that is following CMS guidance, and we're happy to answer detailed questions on that. As you can see in the slides ahead of you, we related to the reporting requirements and what does it mean for a facility to have documentation that testing occurred. We are suggesting that facilities may develop a policy in which they accept attestation of testing from associated providers as verification of completed testing. What that means is that that attestation and your documentation of that will suffice, as opposed to getting an actual test result for an individual. Number 4, facilities must accept testing results from other facilities and not require duplicative surveillance testing. We really want to ensure, especially for those staff that may be going into different facilities, that there is a collaboration and that that results in testing that are done in other facilities are honored. Number 5, we are not requiring facilities to submit a plan to SOQ. We do believe it's a good idea for you to have an individual plan for how you're going to comply with these testing requirements, but that is something that you would have as a facility. You are not going to be required to give that plan to SOQ. You are expected to have that internally and secure contracts on your own. Reiterating some of the reporting requirements, suspected cases of COVID along with positive test results must be reported to both SOQ and the local public health authority. And finally, we want to ensure that facilities cannot mandate a higher standard for staff testing above the state policy unless the following 3 criteria are met. The facility will incur the cost, it's agreed upon between the facility and the contracted staff, and it does not limit resident access to needed services and supports. So with those 2 definitions that I went through in the testing rule, I want to shift to highlight the additional resources of the point of care antigen test and the related guidance from OHA. So on July 14th, many of you have been gifted and have received these antigen testing devices. All of these devices were sent to nursing facilities. Some of the additional long-term care facilities that had a CLIA waiver that were in high positivity community areas also received point of care antigen card test. These devices were issued by the federal government with the intent to help meet testing needs of long-term care facilities, including the mandated screening of staff and serial testing and outbreaks, which we're defining today. Oregon issued guidance on the use of the point of care antigen test in long-term care facilities. What you can see from this chart is that this chart was intended to identify a flow chart for you to consider on when the use of the antigen test would be appropriate versus a PCR molecular test. So as you can see from the top flow, if the resident has symptoms, if they're symptomatic or asymptomatic, you will have 2 different tracks. So for symptomatic patients, we're looking, if you have, you can see if you have access to molecular testing, there's a yes, no box, and I'm looking at, again, the side of the screen that has symptomatic, access to molecular test. If you have access to molecular testing, then we do want you to use that testing. If you don't have access to that testing, then we are saying that point of care antigen testing is appropriate. We did identify that access to testing in this definition means that access within 48 hours that your testing vendor could produce testing results and be able to collect the specimen collection. On the second half of the chart, you're going to see if asymptomatic, we're looking at an outbreak or not an outbreak. If the COVID case, if there's an asymptomatic individual and there's a COVID case or an outbreak in a facility and you have access to molecular testing, we absolutely want you to do that. You can see as well, if you don't have access to molecular testing, then the point of care antigen is appropriate. If the individual is asymptomatic, however, and there's no outbreak, then the antigen test is appropriate, and that's what this chart shows. Now, this chart is included with written guidance to interpret and explain, and I do want to make sure that we're pointing that out. The link is here on this chart. There are updates to this guidance that were just issued this week. First off, Oregon does consider all positive antigen tests as a case of COVID-19. This does diverge from CDC, which requires confirmatory molecular PCR testing in patients without symptoms. This was a purposeful diversion because both antigen and molecular tests display moderate sensitivity, and we don't believe that one can overrule the other without further evidence. So at the end of the day, we do believe that there is more research needed. We know that there are reports, and we've heard from many of you about questions and concerns about false positive antigen test results. OHA is planning a study to evaluate their performance. And in the meantime, with this guidance that we issued, we are suggesting in our guidance that long-term care residents who test positive by the rapid antigen test would continue to be considered cases of COVID regardless of follow-up testing. But additionally, Residents who test positive by the antigen test that do not have symptoms, we're asking to undergo follow-up molecular testing within 48 hours to inform cohorting of residents and staff. You can see in the sub-bullets that those residents should be isolated but not moved to a dedicated facility or cohorted in a shared room with a confirmed COVID positive case unless a follow-up molecular test is also positive. Residents should complete the recommended isolation period using the time-based strategy if the follow-up molecular test is negative. The new updated guidance for requirements for point-of-care antigen test included reporting requirements. We realize that there are many different ways that you are being asked to report, and we want to document that first. So first, reporting to OHA is something that we are asking facilities to do. So you would report to OHA to satisfy both the federal and state reporting requirements. You would be using the OHA COVID reporting portal, and then OHA routes those testing results data to CDC and local health departments. We do have information on how to report testing results to OHA. As noted earlier, you are also asked to report to DHS. Current guidelines ask you to report to SOQ, and we have the emails listed here. A recent change that just came out was the National Healthcare Safety Network for CMS reporting has now required that all nursing facilities report the COVID-19 long-term care module information on point-of-care antigen testing. So this is a new requirement that facilities who've received the antigen test must use, and it is in addition to the reporting requirements outlined in the previous two slides. I'm going to transition into financing. Many of you have asked, we are shifting. Baseline testing was covered by the state, and as we move into ongoing testing, we know that there are questions about how to continue to support the testing demands. At this time, we are recommending that in asking facilities to have direct contracts with private testing vendors. We also are willing to provide a list of laboratory resources and contact information. Many nursing facilities received a point-of-care antigen test. If there are facilities that do not have a CLIA waiver that would like to have access to antigen devices, we are absolutely willing to assist and will assess the resource availability from the federal government. I would also note that those antigen tests should not just be solely relied upon for facilities in that case, because we, again, want facilities to have direct contracts with testing vendors. We also have a memo that we issued to hospice and home health agencies identifying that home health and hospice agencies could request support through local public health agencies for antigen testing devices if needed as well. I would also identify that there are, Mike can bring up later, but there are some discussions underway with the legislature for assessing if there will be availability for continued support to facilities. More to come. I'm going to go into the next sections of the rule. As I noted, I went through the definitions and the routine staff testing requirements. I want to highlight the 5 different sections that are remaining in the rule and the changes that we included. So the first section is the admission and readmission testing. You can see here that the language was updated to require facilities to align with OHA clinical guidance. In the sections of ensuring trauma-informed and culturally responsive testing and consent for testing, we pared down some of these provisions for ease of administration for facilities. However, we do want to ensure that we did maintain provisions because we want to ensure our commitment to health equity and trauma-informed practices. The consent for testing section did not change, and we do have 2 training resources that are available to facilities on the ODHS website on culturally responsive testing and informed consent training videos. On the outbreak prevention testing section, the language was updated to clarify that a facility must coordinate or complete specimen collection for COVID testing within 72 hours of identification of a case. On the reporting section, to ensure that we were highlighting the state law and transition to Real D, we have a cross-reference to Real D reporting and to the CLIA certification section. Now, I want to clarify that we have received the question about Real D reporting and the expectations. The Real D reporting requirements are really directed at if you're using the antigen test and you have a CLIA waiver, you then are a laboratory, and laboratories must then report in compliance with Real D. By submitting your data through the OHA reporting portal, you then are submitting the data that is Real D data and in compliance with the Real D reporting. And that is why the OHA reporting portal is the mechanism for collecting some of that data on reporting. I'm going to move to just a few frequently asked questions. You can see here, there's a question about guidance on retesting. This relates to some of the clinical CDC guidance. You'll see in this answer here that staff that previously tested positive, so they had been a COVID positive case, they do not need to get retested within 90 days of initial infection as long as they don't develop new symptoms of COVID. So once the 90-day period is over, then you would need to resume routine testing. We have a question here that was asked, really asking about insurance coverage. Many providers have asked their staff to work through their insurance for testing. We think that's a viable option for you to continue to seek and seek out insurance reimbursement. However, we understand as well that some private payers, as we move to potentially asymptomatic testing, that might not be an area that is covered. So we understand that there is variation in what insurance coverage will pay for. At the end of the day, we do want to make sure that facilities will need to ensure that those staff are tested regardless of whether they are it is covered by insurance. And then finally, you'll see here, we do have information, and this is information that is available for you to share as well with your staff and residents to document that residents and staff's privacy absolutely will be protected, and that any results are confidential. And part of this is part of the public health response to ensure that we're doing the appropriate contact tracing and investigation to ensure that we're not spreading COVID. And at this time, I do want to transition and invite my colleague, Jack Honey, to present on the limited indoor visitation policy, and then we'll go to questions after that. Jack?
Thank you, Rachel, and thank you for that presentation. There's a lot of information in there, and I'm sure that people have a lot of questions. So I didn't want to take up too much presentation time talking about the indoor visitation policy, but just wanted to give a very quick overview. We believe that there are some good materials out there on the limited indoor visitation policy, which are pretty well self-explanatory. So I'm going to just do a very quick high-level review, and then we'll be very happy to collect your detailed questions and continue providing information about this policy. So on October 23rd, DHS released a provider alert announcing the new guidance and policies for indoor visitation and long-term care. So you can reference that provider alert. We have a link here in the slideshow, and it's also available on our website. This policy outlined the following guidelines for indoor visitation, which would begin November 2nd, 2020. The primary issue is that all facilities must be in compliance with the core principles of COVID-19 infection prevention. And as a quick reminder, those core principles are that you have a comprehensive screening policy in place, not just policy, but protocol and practices. Screening everybody who enters your facility, including but not limited to a temperature check and a quick questionnaire to assess exposure risks. Secondly, hand hygiene and full infection control protocols are appropriate and implemented within the facility. That includes both hand hygiene and other infection control practices for your visitors, staff, and vendors. Also, good disinfecting, cleaning, and high frequency touch surfaces being disinfected regularly, and environmental concerns as well. And additionally, face covering and PPE as appropriate is being used in all cases. And then finally, instructional signage and education to staff, residents, and visitors. So we hope to see throughout your facility signs reminding of social distancing, reminding of hand washing, informational flyers perhaps on best practices for hand washing, PPE use, etc. So if your facility is meeting those core principles, you will use the COVID-19 positivity rate in your county as a metric for the facilitation of indoor visitation. And this will be open to visitors in addition to or beyond the policy and definition for compassionate care visits. And again, we have a much more detailed document that's available on our website, and that came out in the provider alert on October 23rd. And on the next slide, if I could ask someone to just advance the slides, we do have links to some FAQs for limited indoor visitation and another helpful document, which is a quick kind of a short summary document on everything you need to know about limited indoor visitation. And again, if you have any questions or need help with any interpretation of this document, please contact your policy analyst or SOQ, and we will be happy to help you.
So literally, as we're doing this presentation for all of you, Governor Brown is holding a press briefing today, and she's announcing a 2-week pause on social activities in 5 counties. And you can see those 5 counties listed below: Multnomah, Marion, Jackson, Umatilla, and Malheur. And she's also going to prohibit visits at long-term care facilities effective Wednesday, November 11th. I understand that this is going to make some of you very happy and some of you very disappointed. The feedback that we've been receiving on the visitation has truly been mixed. Some of you think it is a vital service that we need to reopen to residents, and other facilities are expressing concerns about the potential increased risk it introduces. So we get it. We understand it was a very tough decision. Ultimately, when we adopted the indoor visitation policy, we thought that the facilities were well prepared to be able to handle indoor visitation after 8 months of experience. And it was a critical time to start promoting emotional well-being for the residents. So we will be issuing an administrator alert early next week, prohibiting indoor visitation at these 5 counties. For the period of at least 11 through 2 weeks. I think it's the Wednesday prior to Thanksgiving. So stay tuned for that. I also wanted to raise 2 important points on today's presentation. So on the subject of outbreak testing, you may recall that the requirement is to do specimen collection within 72 hours. I want to make it crystal clear that 72 hours is in no way a recommendation of the department. That is the absolute longest that a facility would ever have to take to collect those specimens. Our recommendation is to do it as quickly as possible, but we thought from a regulatory perspective, the 72 hours was necessary because of different variables. The other thing I wanted to announce today is that we fully understand how expensive testing is. And so on Monday, the Legislative Emergency Board is going to be taking up an action to allocate additional funding to the department to reimburse long-term care facilities for costs incurred for testing all of their staff members on complying with basically the policy that we outlined for you today. While it's by no means a guarantee, I would say that the likelihood of them allocating that funding on Monday is very high. And when they do that, we will resume reimbursing facilities for the staff testing costs that they are incurring. And for any that had already submitted invoices, but were not paid due to the depletion of our available funding, we will be processing those invoices on in the order they were received. There is no need to resubmit any invoices. So lots of information shared with you today. I think, are we ready to move on to the question and answer session?
All right, if you are ready, we do have a few questions, a lot of them regarding home health. This one's saying, we don't have contractual relationships with long-term care facilities. The contractual relationship is between home health and/or hospice and the patient. Would home health and hospice personnel be required to be tested before entering the facility?
So this is Rachel. I just want to acknowledge, I'm not sure if we have, I don't think we have our hospice regulators on the call today. But I do want to highlight that in the rule, in the guidance, we did the Oregon Health Authority HSD Health Services Division did issue guidance to hospice and home health agencies highlighting the rule. I do know that there is a question because of the language of contractual relationship. I believe, where we are is that we do believe that hospice and home health, because you are entering facilities and you are directly working with with individuals and residents, that we would want to have home health workers be tested.
Okay. Another question regarding home health. How do we ensure patient care until we can test our staff? Some facilities are declining our visits or wanting our insurance info in order to test on site. This might not work for us because the labs are unlikely to be our preferred providers on our insurance.
So I think that's something that the facility, and it sounds like the home health agency, are continuing to navigate, and it sounds like you're doing the right things by having those discussions.
And I would, and Jack, I need you to check me on this, but I would also add that if a facility declines entry to a home health agency, then they are in effect assuming responsibility for administering all of those services.
That is correct.
Okay. Are there screening checklists available for staff, residents, and visitors which capture all the data points for each group?
At SOQ, we haven't put together any official screening checklists or made any required, but we do have a few samples and examples of good screening checklists that some facilities have been using. So if you contact your policy analyst directly, we will be more than happy to share with you some good comprehensive checklists for screening.
In Marion County, we can allow indoor visits for residents that are on hospice and transitioning. Are we allowed to have indoor visits for residents that are on hospice and transitioning?
Yes, the governor's order does not apply to compassionate care visitation. And we will make sure that that is clear when we issue our administrator alert next week.
Okay, and more clarification on home health. Who tests them? Who tests home health and hospice, especially when they send multiple staff in?
So I'm going to go back to, I think for all of the home health and hospice questions, and I see quite a few, happy to, part of this is we know that there are questions, and we're happy to take some of these back and to continue to identify what other questions and supports you need. With the hospice and home health memo that we issued, we did identify that it is the expectation that hospice and home health agencies, we anticipate you'd be able to test your staff if you need support, because you do not have access to testing support. That's where if for example, you needed access to an antigen test or cards right away, in the email, in the presentation, we did have the link to that memo that identifies for where you would go to request potential services or supports from the local public health agencies. So I think that's kind of the first ask. I do think as well, if there are facilities, for example, that have antigen tests and that are and you have the antigen machines and you need your home health and hospice workers to enter those nursing facilities, considering working with those facilities to ensure that those devices potentially could be used. That's another resource you have. So I do think that at the end of the day, I know this is a challenge because the requirement and how this is issued is on the facility and who can come in the door. And that means that there are impacts on other types of providers who need to serve individuals.
And we will have a recording and handouts from this presentation on our website once the live event is over. Another question, do we have data on incidents of LTC outbreaks from residents bringing viruses into the facility as opposed to staff?
This is Rachel. Yes, I think with our contact tracing and with, I just would go back to where Mike McCormick presented at the beginning with the number of executive orders and confirmed or suspect. I cannot speak to all of the epidemiology, but I'm sure that we do have cases where there are both residents and staff who have COVID, correct? I don't know if Mike or Jack, you have anything more to add you'd want to state there?
The Oregon Health Authority may have, I think their question is the origin of patient zero. Do we have statistics
data?
on how many times the resident was patient zero? And I believe that the Oregon Health Authority may have that data, but I'm not prepared to answer the question today.
Mm-hmm.
But I can say with a high degree of confidence that the vast, vast majority are related to staff members bringing it in.
I would only add to that although we acknowledge that residents have the same rights as everybody and are coming and going quite frequently from the facility, but we do know that 100% of your staff are coming and going, and there are it's much less certain what they're doing and where they're going outside. So the important thing, though, is every individual, when they come into the door, what are you practicing inside the facility? And from SOQ anyway, that would be our perspective, is we may not have the data on from contact tracing and that epidemiological information, but we want to see how you're treating everything on the inside of your facility and preventing that COVID from spreading if it does come in, regardless of the source.
Once we get our CLIA waiver, how do we request the antigen test kits?
So if you are a facility, we included on the slides a link to an email address which you can use to submit a request for consideration to the testing branch at the state.
Can we get some direction on how to maneuver around getting orders for employees? Labs require an order to get our employees tested. Our small RCF does not have a medical director, and providers are refusing to provide standing orders for both employees and residents. How do we even do this when testing is required to be done twice a week?
Sure. So in terms of standing orders, I want to acknowledge that the Oregon Health Authority does have a model standing order that they've issued for local public health agencies to use for testing. So the first thing we would ask is we'd ask facilities to contact their local public health authority to see if that standing order for testing could be used. If that's not possible, potentially when you're contracting with a testing vendor, sometimes the testing vendors would be able to provide access to physicians to assist for orders. And those are two mechanisms.
Can you please review the state's expectation on when you want to be notified of testing? When you say you want notified of a suspected employee, is that anyone who is off with a symptom, i.e. someone off for a headache, or how about ongoing testing notifications?
Jack, do you want to take that one from the executive order standpoint?
Yeah, for SOQ, we pretty much want and need to be notified as soon as possible when you do have a suspected or confirmed case. For confirmed cases, absolutely, we need to be notified immediately, same day. For suspected cases, a suspected case is anybody that's being tested for COVID because there is a chance that their symptoms may be indicative of COVID-19. So if somebody has been, has some symptoms, but their medical provider has cleared them as having the flu, for example, these are very rare instances that it may not be COVID. If someone has symptoms and you don't think they have COVID, but you're testing them just in case, that is a suspected case of COVID. And same with confirmed, we will want to be notified as soon as possible. How we move forward with it, we'll work collaboratively with you and look at the actual situation, but we do need that communication immediately.
Should we continue to submit unreimbursed testing costs to DHS?
I would, because we're submitting it in the order in which it's received. I would highly encourage facilities to submit them as they complete them. I also want to take this opportunity to give a friendly reminder that if any facility did the baseline testing that was ordered by Governor Brown and had unreimbursed costs, there is no limit on that funding, and there was a separate invoice form. And that was included in an administrator alert that went out on Monday. So any reimbursed costs, get those invoices in and we'll get them paid.
And Mike, just clarification on indoor visits, does that only apply to the 5 counties or all of Oregon?
The 2-week pause on indoor visitation is only going to be applicable to those 5 counties.
Okay, what is the process for us to get the memos from DHS and OHCA, or OHA, sorry?
So I think that I'm just saying, yeah, I think, so I just want to acknowledge on the DHS testing website and in this PowerPoint slide deck, we do have links to all of the memos and documents. So I would say continuing to go to that website, you can look at, that could be your resource.
I'd like to
add to that.
I would like to ask, before Jack starts, Elisa, can you please add the URL for the testing webpage? Sorry, Jack.
No problem.
Yes, I will add that to the chat, yes.
Thanks, Elisa. I was just going to add very quickly, all of our alerts and guidance that go out to providers from SOQ, you will automatically receive them in email if you are registered to receive provider alerts. And we are doing most communication around COVID and other regulatory issues via those provider alerts. So I strongly encourage you all to go in and ensure that you are registered to receive them, that you have been receiving them, and that all of your recipient emails are correct in your registration for provider alerts. And when you go into the website to retrieve the provider alerts, you should be able to find instructions there or contact your policy analyst and we'll get you set up right away.
Where do we follow up unreimbursed baseline testing that was submitted to DHS?
You can send an email to that original email address that the invoice was sent to, or if you're not getting a response there, you can send an email to me directly. And I'll go ahead and add my email address in the chat box.
If we go to bi-weekly testing, what do we do if our results are not back yet from the first week of that first testing of that week?
This is Rachel. I guess I will jump in. I guess to answer that question, we would ask that you would continue to spread that out and to think about the week in that 7 days. And we would hope that, again, with the guidance of trying to have timely access to testing, that you'd get the PCR molecular test within the 48 hours. If you can't do that, you could use the antigen test, which are rapid tests. So we would just ask you to do your best and to continue to work to meet the requirements.
Okay. Sorry, I'm going through these questions. Clarification, how do home health and hospice get DHS updates? We're not aware of the testing required of us until last week, which facilities, decline, not aware of the testing required of us until last week with facilities declining entrance a day later.
Yeah, so Lynette Caldwell has published the links to our provider alerts in the chat. Any member of the public can sign up to receive those alerts. So that's where you can go and sign up.
And this is Lynette, just real quick. I updated a couple of the quick links because they only went to us as the panelists and not to the attendees. So for some of you seeing them twice, that's why I wanted to make sure the attendees had them.
And a home care scenario, which associated staff should be tested within 72 hours. Home health worker sees resident Jane Doe on Monday. Staff who wasn't working Sunday through Wednesday is back to work on Thursday and test positive on routine screen testing. Do we test the associate staff member who was in the building on Monday? What about the one who was there last week?
So that's a complicated question. As I am attempting to follow it. So I guess, so I'm just going to note part of what we're trying to do here, and the intention of the staff definition, is to say those individuals, if we know that staff, especially those who are working in multiple facilities that are coming into close contact with residents, are where we do see COVID entering facilities, the intention behind the rule is to ensure that we are testing those staff. So I do believe, I'm not sure if I can comment on the specific scenario. I would just note that going back to really that expectation and philosophy, that the reason why we're doing this is to ensure that those individuals who are working with people closely are who we're asking to get tested. Any other, if my colleagues want to chime in on how we'd handle that, that's where I would leave it.
I don't have any additional comments, Rachel, except that for one scenario, if we address it, there are myriad other scenarios. So, and there will be complications. There will be challenging situations that you're facing, and you may have these questions even if we did address this specific scenario. So I just encourage you again to contact us and work with us if you do have those kind of situations and you're unsure. However, for the most part, err on the side of caution and get everyone tested who has been and will be in the facility working with your residents in the case of an outbreak.
And do independent living facilities have to test employees?
No.
Okay. And can you repeat the counties that are excluded from the visitation?
Sure. Multnomah, Marion, Jackson, Umatilla, and Malheur.
Thank you.
Okay.
Have you considered having home health and hospice have testing requirements since they all go between facilities?
So thanks, Catherine. And I'm just going to acknowledge, I know that there's a whole host of home health and hospice questions today. I'm happy to follow up with, to make sure that we are helping to address some of those, your questions specifically. By putting the definition in the DHS rule of staff, by stating that facilities must ensure, again, facilities must ensure testing of these staff and associated staff, we are by definition then stating that those staff have to be tested. So I understand that the mechanism to do so is through the DHS rule and its authority and regulations with facilities. And that does mean then that facilities have communication and support and work that they need to do to help work with hospice and home health agencies to become into compliant. The idea is that you would continue to partner, that there'd be support, and we'll continue to follow up to see if what else we can do to help clarify with home health agencies and hospice overall.
Okay, and that's all the time we have for questions. I'm so sorry if we didn't get to all of them today, but we're going to compile all these questions into the FAQs and watch out for updates from DHS. So thank you so much, Rachel, Mike, and the team for being on this webinar with us today. Again, look for those updates. We are recording this webinar, so we're going to have that on our website with the handouts as soon as it processes. And I'll go ahead and email all the attendees with that info as well. So thank you so much. If you have questions, please email me at cvan@ohca.com. So thank you and happy Friday.
Thank you.
Thank you.